Welcome to the video training series. I'm Lori Summers. I'm the trainer for the Iowa Cancer Registry. This presentation covers the treatment for breast cancer, including surgery. The invasive breast NCCN guidelines is copyright protected. In fact, all of those pamphlets and booklets are, but there are so many details to the treatment. I will just briefly talk about some of these treatments based on if it's invasive or DCIS. They even have NCCN guidelines for metastatic breast cancer. So the NCCN, or National Comprehensive Cancer Network, is an alliance of leading cancer centers across the U.S. devoted to patient care, research, and education. Guidelines are developed by doctors from the NCCN cancer centers using the latest research and years of experience. These are providers that are all over the world. The best resource is what they publish for patients, and it really breaks it down to very plain terms and steps from diagnosis and treatment to outcomes. So if you are looking for a particular resource to understand what kinds of treatment would be considered for breast or lung or colon, any of the primary sites, NCCN is your best resource for understanding what would be considered usual or customary treatment. And for breast, they do break down the guidelines based on invasive breast or non-invasive breast cancer. And then they do give special consideration to different histologies and diseases of the breast. So treatment is not just a simple cookie cutter approach anymore. It is getting to be very tumor specific. You will see that there are numerous options depending on the specifics of the breast cancer, the stage, the histology, all of the biomarkers. So we're going to just briefly take a look at these next. Also, a couple of terms to keep in mind, adjuvant and neoadjuvant. Especially neoadjuvant should kind of just give you a yellow flag when it comes to staging breast cancer and really for treatment. So adjuvant aids or contributes to therapy. It's typically given post-op where there's actually no disease present, but it's an insurance policy. Whereas neoadjuvant therapy is systemic or radiation treatment administered prior to surgery in an attempt to shrink the tumor or destroy regional mets. I do want to spend some time going over the surgical procedures and codes, especially also the lymph node surgery. This has always been an area that can be confusing. And the SEER manual does an excellent job of explaining the lymph node surgery. It's just that we don't always have the time or that access to go back through and read paragraphs of what they're talking about. This will be changing in 2023. So basically, we'll just look at the surgery for breast that is current for 2018 to 2022 cases. For the surgery of primary site, use the entire operative report as the primary source document to determine the best surgery of the primary site code. The body of the op report will designate the surgeon's planned procedure as well as a description of the procedure that was actually performed. And this area of the op report is golden. You find a lot of information in there. The path report may be used to complement the information appearing in the op report, but remember the op report takes precedence because you're coding what the surgery was to the primary site. You don't need to know the outcomes yet, but you just need to know the name of the procedure that was done. Also, you want the most invasive, extensive, or definitive surgery if the patient has multiple procedures of the primary site. Even if the most definitive surgery has no residual, remember, you're not coding the outcome of the procedures. At this point, you're just coding what procedure was done. The surgery of primary site section in the SEER manual gives guidelines on how to code this field. So, for example, in Note 4, you would code the excisional biopsy even with documentation that it's incisional when all of the disease is removed and the margins are free, or all the gross disease is removed and you only have microscopic residual at the margin. And then a reminder in Note 1, do not code incisional as excisional when the macroscopic margins or there is macroscopic residual disease. So this doesn't happen that often. It's not the intent when they go in and do a stereotactic needle biopsy of the breast, and they take out the samples that they're getting and they go back and do a resection of the breast and there's no tumor. So it was never the intent of that incisional to be treatment. But if that happens, this is what they're talking about here in Note 4, you would code the incisional as excisional. It would be an excisional biopsy because it got all of the disease. So BCS, or breast conserving surgery, removes the cancer but not the entire breast. So some examples of that are lumpectomy or partial mastectomy. Those are two types of BCS. The lumpectomy just removes the tumor or the lump and some of the normal tissue around it. The partial mastectomy is surgery to remove part of the breast that has cancer and normal tissue. And it also might be called segmental mastectomy. So it's a little bit more extensive surgery than just the lumpectomy. So think of it as you're looking at these reports, what to expect for these types of procedures. A small portion of the breast is removed to excise the tumor, which you can see there in the triangle. Watch the wording carefully in the op reports. There may be a sentinel lymph node biopsy, or there may be a lymph node dissection. Those are two different things. It will mainly rely on if the lymph nodes are palpated on exam, or if there's nothing found on exam. So if lymph nodes are palpable, you could expect a dissection. If the lymph nodes in the axilla are not palpable, a sentinel lymph node biopsy most likely will be done. Okay, so here are the 20 range surgery codes for breast. This first section of codes are the BCS, or the breast conserving or preserving surgeries. There is a SEER note that reconstruction still only is, when there's reconstruction, you still only want to code the surgery. If there are additional margins, in order to code 23 for re-excision, if you're looking down there at the bottom of the slide, it has to be a separate surgical event, separate anesthesia, separate hospital visit to qualify to code a 23. Otherwise, if they're just doing a lumpectomy or a partial mastectomy and they go in and do the margins and send them to path and send a note back to the surgeon, nope, the margins are still positive. They go in and carve out a little bit more. When all of that is done under the same procedure, that does not qualify for a 23 for re-excision. That's all done And those would be coded like a 20, 21, 22. Code 30 includes reconstruction. Read the operative note carefully to determine if the nipple and the areola complex have been removed. And then check and see if that specimen is in the path report. So a subcutaneous mastectomy could also be called nipple-sparing mastectomy, which means they left the nipple. It is the removal of the breast tissue without the nipple and the areolar complex. It is performed to facilitate immediate breast reconstruction. So remember, we're not coding the reconstruction. We are more concerned about what the surgery code was to the breast. You can assume or consider that cases coded to 30 will have undergone a breast reconstruction. There is a SEER note under code 30. The SEER notes will only be found in SEER Appendix C surgery codes. If you're looking in the store manual, you will not find those, but because Iowa is a SEER state, we do have these SEER notes that do help explain a little bit more about these procedures. So code 30 also would include a Goldilocks mastectomy. And if you're seeing that term, it essentially is a skin-sparing mastectomy with breast reconstruction. And so they would take the nipple and the areolar complex for skin sparing, which is different than nipple sparing. But it's basically the same intent, is to prepare the breast for reconstruction. Just to talk about this concept a little bit with the subcutaneous mastectomy, the code 30. So whether you see nipple or skin sparing mastectomy, it removes the entire breast and the lymph nodes, but they try to preserve about 80% of the native breast skin. It does facilitate immediate breast reconstruction. And so as you're coding 30, don't feel like you're missing something because it doesn't really reflect reconstruction, but you can be assured that it does imply that reconstruction was done. For the terms nipple sparing or skin sparing, simply text what the operative report information describes. There was a comment in the forum that talks about the data item skin sparing mastectomy, which we've clarified that to be a code 30. A note is included in the breast surgical code 30, the SEER note that we looked at. And so a lot of times this wording can be a little bit confusing, and you don't have to interpret so much as just look at what was done in the op report, text that information, and then go to the Appendix C to look at the surgery codes. Here is a picture of a total simple mastectomy. The dotted line shows where the entire breast is removed, and some lymph nodes under the arm might also be removed. This is not necessarily a formal dissection. They take what they get with the lymph nodes, and these would be considered intramammary nodes or within the breast tissue nodes. So look for details in the op report and text if it says axillary nodal dissection was done or regional lymph node dissection was done, or were there just lymph nodes in the specimen when they took it out. And you can see here they're not actively going after the lymph nodes in the axilla, but you can see there are lymph nodes in the actual breast specimen. Here are the surgery codes in the 40 range. Remember, for this group of codes, there is no axillary dissection. So if you only have a sentinel lymph node biopsy and a mastectomy, it is coded here. If you have a mastectomy NOS and an axillary dissection, you have to move up to the 50 range codes. Based on the note at the bottom here, a simple mastectomy removes all the breast tissue, the nipple, the areolar complex, and an axillary dissection is not done. So that's your telling factor right there. If you have an axillary dissection, it is not coded in the 40 range. There are numerous notes in this surgery range, and you can see that these codes do allow for reconstruction information. The source document for this information is still the op report, and text the best that you can based on the procedure that was done. I want to highlight these because it will hopefully jog your memory when there are some additional notes for these codes. Here are the surgery notes for the codes in the 40 range. You can see it includes also 75 for the bilateral mastectomy, which is often used for inflammatory breast cancer. But before we go on to the 50 range codes, I want to just cover what they're talking about here. So there are some SEER notes for reconstruction. If you're talking about reconstruction tissue, that literally is human tissue or skin that is either flapped around or rotated to create a new breast. The SEER note second bullet, assign code 43 for a simple mastectomy with tissue expanders. And that would be like an alloderm or a matrix. So they put in a tissue expander so that they can expand the skin over the breast so that they can later go back in and put in the implant. So tissue expander, the naming of that is very confusing when we have a code for reconstruction tissue. So a reconstruction tissue expander is actually an implant. So use those words very carefully. Clear at the bottom, the SEER note, a tissue expander at the time of original surgery does mean that reconstruction is planned as first course treatment. Coding the mastectomy and the reconstruction, so those codes 43 to 49, are included regardless of timing. So that tissue expander could be put in, typically it's done at the time of the mastectomy. So here's a diagram of the modified radical mastectomy. The dotted lines show where the entire breast and some of the lymph nodes are intentionally removed. Part of the chest wall muscle might also be removed depending on how deep that tumor is. So here you can see that they are intentionally doing the axillary lymph node dissection. This group of codes begins in the 50 range. So this is removing a lot more information, tissue, skin, lymph nodes. They may or may not go deeper, but this is a modified radical mastectomy. And remember, we're coding the most invasive or extensive or definitive surgery. And so if they had a stereotactic needle biopsy, and then they go on to have a modified radical mastectomy, this is the code that you're coding. And here are the notes for the 50 range codes, up to 50 to 59, and then also 63. The 60 range codes are for radical mastectomy, and those really are rarely done now. For most cases, a more definitive surgery like a mastectomy will not be followed by radiation. So depending on the nodal status, you might see chemotherapy following this type of surgery. Comments from Dr. Erdahl at our state association meeting stated that the lumpectomy option will depend on the tumor to breast size ratio, the patient goals, the risk of future cancer, feasibility of radiation. So choosing a mastectomy also depends on the tumor size, recurrence, or if there are multiple tumors, as well as the patient's age and genetic or hereditary cancer syndrome. So if you think about these more definitive surgeries, obviously they're taking a lot more tissue, taking the lymph nodes. So these SEER notes refer to, again, do you have tissue reconstruction, which is human tissue, or do you have implants, which are tissue expanders? And so if you can keep those straight in your mind, tissue expanders often get coded to a tissue type of reconstruction, and it's very different when they're taking human tissue from a back flap and keeping the blood supply and rotating it around to the front of the breast versus just removing the breast and inserting a tissue expander so that that can be blown up at different increments to make room for the implant. Two very different types of reconstruction. So assign code 51 or 52 if there was excisional biopsy and an axillary dissection, followed by a simple mastectomy during the first course of therapy. So we are coding cumulative results of surgery because an axillary dissection was done. This is a modified radical mastectomy. If the contralateral breast reveals a second primary, each breast is abstracted separately based on our solid tumor rules. You would code the surgery code 51 for the first primary and code the contralateral breast according to the procedure on that side. So these, once you figure out you have two primaries to abstract, they really do become each their own abstract and each their own primary, and then you code just what was done on that breast. For single primaries only, code the removal of the involved contralateral breast under the surgery of other field. And that does not happen very often. There are some other notes regarding that. I want to look at looking at the reconstruction. Just the wording can cause confusion because, like I said, the tissue expander word, people automatically grab the tissue code. And so tissue expanders, if you think of those as a two-step or a two-stage type of reconstruction where they're trying to expand the tissue of the breast to make room for the implant. And that is not the same thing as the transfer of human tissue to the breast to create a new breast. So read the codes carefully. Human tissue reconstruction will actually move the tissue from one body site to the breast. So the path report will define this process in the reconstruction, probably the op report. And depending on what they remove, obviously you will see that in the path report. There are numerous YouTube videos available, and I'm a visual person. I like to go to YouTube and search the procedure just to get a visual of what the surgeon is talking about in the chart. So here's a picture of the two types of implants, and I tried to keep this as simple as possible. Code 45, the implant is where they describe the two-stage procedure where they create the pocket, put in the tissue expander for a later placement of an implant. So the tissue expander is actually the first stage, and that is reconstruction implant. If you look at code 44, here's where I was talking about them taking tissue from a different part of the body And so they can call this a TRAM flap, transverse rectus abdominis myocutaneous flap. And here the patient's tissue is used to form a new breast. And so they don't necessarily cut out that tissue and move it to the breast area because they need to keep the blood supply intact. And so I've seen them ellipse this tissue, the skin, fat, and muscle from the abdomen, but they don't dissect away the blood supply, and they slide it up underneath, tunnel it up underneath the skin to where the breast is going to be created. So it's just very interesting if you pull up a YouTube video and look at that. So a couple of important things to remember when coding breast surgery is the codes 22 versus 23. And the SEER note explains that pretty well. If you're just getting additional tissue for a positive margin during the same procedure, that's a code 22. If they send them home and they decide they need to go back in and take some more margins, they bring them back into the hospital, different anesthesia, different operative room, different staff, then you would code a re-excision 23. And then the bottom example is the 41 versus 51, and that is covered under the SEER note regarding the axillary dissection. So an axillary dissection is not done in code 41. If the dissection is done, you will move down to the 51 codes. And so it's not naming it exactly how it is in the manual, but it's driven based on if an axillary dissection is done. So you could have a total mastectomy with a sentinel lymph node biopsy plus that lymph node dissection will be down into the 50 ranges. If all you have is a sentinel lymph node biopsy, or they don't even do that, they just get some lymph nodes out of that intramammary tissue, that would be a simple mastectomy. So cautiously look through those codes. Do take time to read the SEER notes because they are very helpful. Okay, let's take a look at scope of lymph node surgery. This is a procedure that describes what was done for the lymph nodes. Did they remove them? Did they aspirate regional lymph nodes? So the sentinel lymph node biopsy is the first node that is draining that tumor. And like I hinted before, if they cannot palpate any lymph nodes in the axilla, they will want to do a sentinel lymph node biopsy. And so they take a needle, they inject dye into the tumor, and then they use a Geiger counter to follow that dye to that first lymph node, and they take that out. That is a sentinel lymph node. It's the first defense going into the lymph system. They will take that out. If it's negative, they probably will not go on to do a lymph node dissection. If it's positive, if that sentinel lymph node is positive, they probably will go on to do an axillary lymph node dissection. So you can see that it really depends on the results of the extent of what they're going to do. So we are trying to describe in scope of lymph node surgery the procedure of removal, biopsy, or aspiration of regional lymph nodes during the initial workup of the first course therapy. So in the SEER manual, there are pages of reminding us with the scope of regional lymph node surgery. This is taken from the op report. We do not count lymph nodes to try to decide if it was a sentinel or if it was an axillary dissection. We are looking for what procedure was done. Was it sentinel only? Was it sentinel with a regional lymph node dissection? Did they try to do a sentinel and none of the dye went to any of the lymph nodes? They call that fails to map, but the procedure was still done, that they injected the dye and tried to do a sentinel lymph node. So there's very good details in the manual of kind of spelling out these different steps. Remember, this is regional lymph nodes only. The scope of regional lymph node field is cumulative. So we are looking for the procedure of all the lymph nodes removed during the surgical procedure during first course therapy. Code the removal of the regional nodes for both primaries when the patient has two primaries with common regional nodes. Okay, so sentinel lymph node biopsy. Let's look at this third bullet here. When a sentinel lymph node biopsy is performed, additional non-sentinel nodes can be taken during the same operative procedure. These additional non-sentinel nodes may be discovered by the pathologist or selectively removed or harvested as part of the sentinel lymph node biopsy procedure by the surgeon. This is still coded as a 2 for sentinel lymph node biopsy. If you review the op report and you can confirm that a regional lymph node dissection is stated to be done, and it did follow the sentinel lymph node biopsy, then these would be coded to a 6. So let's look at the codes. This is from the SEER manual, Scope Regional Lymph Node Surgery. Use the entire op report as the primary source document, looking for the procedure that was done. So always start by asking, was a sentinel lymph node removed? If you at least have a code 2, you cannot have a code 3, 4, or 5. Code 2 jumps to a code 6 or 7 if there was a sentinel lymph node biopsy followed by an axillary dissection. If you did not have a sentinel lymph node biopsy, then you typically would have a code 4 or a code 5. And those you are actually looking to see how many lymph nodes were found in that dissection in order to code this. So please take time to look through these instructions in the SEER manual. It goes over each code and how to code for breast cancer. Remember, do not count the number of nodes to determine the procedure done. Look at the op report, look at what procedure was done, and then you will be able to code this consistently and accurately. Code 1 would be if they only did an excisional biopsy or aspiration of a lymph node. The lymph node needs to be removed or aspirated. Code 2 is the sentinel lymph node biopsy, and they did not have an axillary lymph node dissection. So look in the op report to see what was done. And in the texting, give us the procedure of what was done during these operations. And then code 3, 4, or 5, generally, an axillary lymph node dissection removes like 7 to 9 nodes, but it's not impossible to have fewer nodes than that. Again, look at the op report, confirm that there was no sentinel lymph node biopsy. They don't want to lose the fact that a sentinel lymph node biopsy started the process, and even if it fails to map and they go on to have an axillary dissection, like I said, if you start with a 2, you won't end up with a 3, 4, or 5. You'll end up with a 6 or 7 based on a lymph node dissection being done after that sentinel lymph node biopsy. And it depends on if it was at the same time or a different procedure. So just another graphic of what they do with the sentinel lymph node biopsy. You can see the tumor is palpable, so they inject the dye in there, and then they follow the dye to that first lymph node with the Geiger counter or the probe inside the tissue, and then they take that node out to see if there are cancer cells in that first node. And then we are capturing the date of the sentinel lymph node biopsy. This was a new field for us in 2018. It is required for breast and cutaneous melanoma only. Record the date of the sentinel lymph node biopsy only, but do not include an FNA, a core needle biopsy, or a core biopsy of a lymph node in this field. If a sentinel and an axillary lymph node dissection was done at the same time during the same date, then these dates will be the same. This was a new field for 2018 and forward. There are 5 notes in the manual. The sentinel lymph node examined and the sentinel lymph node positive apply to breast and cutaneous skin only. So in this field, you want to document the total number of sampled lymph nodes during the sentinel lymph node procedure, even if sentinel and non-sentinel nodes are sampled. Add those together. They want to know the total number of the nodes from the actual procedure. The number of sentinel nodes should be equal or less than the number of regional nodes examined. So for breast and cutaneous melanoma, you have an extra set of lymph node fields that you will be completing. So that was sentinel lymph node examined. Now we're going to code sentinel lymph node positive. I've only highlighted a few of the notes here. Remember, just for breast and cutaneous lymphoma do you have to fill this filled out. But you want to document the total number of positive nodes identified during the sentinel lymph node procedure. And the number of positive nodes should be less than or equal to the number of regional nodes positive field. So for breast only, use code 97 when positive sentinel lymph nodes and sentinel lymph node biopsy was performed during the same procedure as the regional lymph node dissection. So for this field, sentinel lymph node positive, if you have both procedures done on the same day, this will be a 97. Sentinel lymph nodes are negative when only positive isolated tumor cells are identified. And just a few common coding errors for scope of regional lymph node surgery. If there was sentinel lymph node mapping done and a biopsy only, then that correct code is a 2. If there was a sentinel lymph node biopsy plus a dissection, you have at least a 2, and then you have to skip codes 3, 4, and 5, and you would have either a code 6 or 7. The correct code would be 6. That's a very common code that gets used. If you have a right breast mastectomy with a sentinel lymph node biopsy, then the scope would be coded to a 2. If you have a left total simple mastectomy, a left axillary sentinel lymph node excision, read that carefully. That is a sentinel lymph node biopsy. It is not a formal lymph node dissection. You have a total of 5 nodes that were taken. 0 out of 5 were positive. You would still code this to a 2 for sentinel lymph node biopsy. One of the terms that Dr. Erdahl used at one of our meetings was targeted axillary dissection. And you might be seeing that in some of your records. It is the exact same thing as a sentinel lymph node biopsy. Okay, so we'll just look at some of the adjuvant therapy for breast, starting out with chemo, but we'll also look at radiation, what to expect with endocrine therapy, some targeted therapy, and clinical trials. There are a lot of considerations that come into play when the doctor decides on chemotherapy. By adding chemo to the regimen, some patients get improved results. As you know, with Oncotype DX, treatment is planned by looking at the risk of recurrence. So taking into consideration what is the hormone status and the HER2, were the lymph nodes involved? Was the HER2 positive status, which means they would qualify for Herceptin? Or was it triple negative? So that would mean ER, PR, and HER2 all negative. So these tumors are not responding to estrogen, progesterone, or Herceptin, and they do have a worse prognosis if they're triple negative. So that might be a time when only systemic chemotherapy can be used. This is a very small list, basically a drip in the ocean of medicines that they are now using for breast cancer. Many of these are proven and therapeutic. They are not considered precisional or personalized drugs, but general regimen for breast cancer treatment. Remember, we have SHRI. If you ever come across a drug or a regimen that you need to look up, and SHRI will tell you which category to code that in. According to the NCCN guidelines, many women with invasive breast cancer receive radiation therapy. It may or may not be given if recurrence is likely. It may be omitted in women over 70. And if a patient has a T1N0 tumor, or if the patient will receive endocrine therapy, a lot of times they will not do radiation therapy. So it usually follows a lumpectomy or any of those other BCS types of surgery. If it's given pre-op, it's used to shrink larger tumors before surgery. Post-op, if they cannot successfully remove a tumor, depending on the location, they might do radiation post-op. And it's also used to treat chest wall recurrence or metastatic disease. This type of radiation only treats the lumpectomy site where the tumor was removed. Even if the specific mammocyte brand is not being used at your facility, the APBI, or accelerated partial breast irradiation, is still being used. More research is needed on how this works, but this is the safest among older women, 50 years and older, with hormone positive T1N0 tumors that have been removed. And also the BRCA genes should also be normal. So this is a catheter that they insert, they give radiation for 5 days, and then they remove the catheter. And so it's a very much abbreviated type of radiation. And I haven't looked lately to see if they're still doing radiation 5 days a week for 6 weeks. I feel like a lot of them are getting now this accelerated partial breast irradiation over 5 days. And that might be more the norm of what is being. So intraoperative radiotherapy is administered as a single treatment during surgery. This is convenient for the patient, obviously, because they don't have to keep coming back to radiation therapy. So the radiation therapist and the radiation physicist calculate everything in the OR. And so they would take do the lumpectomy, and then that lumpectomy cavity or the tumor bed is where they would deliver this radiation to that cavity. It takes about a half an hour, and they remove the device and suture back up the breast, and that woman has had her radiation. So if you see a patient with a larger tumor at diagnosis, one treatment may be to radiate the tumor first to shrink it. We see this in other sites like the anus or the rectum, maybe not so much in breast with radiation pre-op. There was a study I found that looked at these larger tumors, 2 centimeters or greater, or with positive lymph nodes. And so then they would do the pre-op radiation, hopefully followed by surgery if radiation made it feasible. And then they tend to have a good long-term local regional control of their tumor. And it's based on bigger tumors, so T2 to T4 tumors, and then N2 would be the nodal, they would have nodal disease. Remember that little yellow flag with neoadjuvant, it does alter your thinking as you're filling out treatment information. Did they have treatment before surgery? Did they have radiation before surgery? And so just remember that when the word neoadjuvant pops up, that is a yellow flag. While we're talking about neoadjuvant therapy, I want to point you to the breast specific codes for neoadjuvant therapy in the SEER Appendix C manual. Remember, we looked at the 3 related neoadjuvant therapy fields for all sites. In addition to those 3 fields, we looked at breast has 1 SSDI that covers neoadjuvant therapy. But if you're looking for the site-specific codes for breast for the field neoadjuvant therapy treatment effect, this is where you will find that. This is not the SSDI. This is the site-specific neoadjuvant therapy field. Again, there's that yellow flag of neoadjuvant. So for breast, if you look at the big picture here, there are 4 fields related to neoadjuvant therapy. The first one we looked at in the SSDI video of response to neoadjuvant therapy. This is the clinician's statement of the treatment effect. How did this patient do with neoadjuvant therapy? That SSDI is only collected for breast. Now, looking at these other 3 fields, these are for every single site. They are not just breast specific. These 3 fields are in the SEER manual. So when you have a case with neoadjuvant therapy, let that yellow flag fall. Go back to the manual, read the details of these fields. In the SSDI video, there's also a table that I created looking at these fields. So 16, 32, 33, and 34 are for all primary sites. They are asking different questions. 1632 was neoadjuvant therapy given. 1633 is the clinical outcome. And then 1634 comes from the path report. It is the treatment effect. What does the pathologist say about their response to neoadjuvant therapy? And there's our yellow flag. Just as a reminder, let the word neoadjuvant trip that yellow flag for you. Okay, so let's look at endocrine therapy. There are 5 main types. Ovarian ablation, the LHRH antagonists, the aromatase inhibitors, and the anti-estrogens. So think of ablation as stopping, it stops the ovaries from making hormones. Suppression stops the ovaries from making hormones, but it is temporary. Aromatase inhibitors stop the hormone androgen from changing into estrogen, and the anti-estrogens stop the hormone receptors. It blocks the estrogen from attaching to the receptors. So you can see that they all have an effect on the production of what causes tumors to grow. And so here are some examples here on the slide as far as ovarian ablation, or are they actually removing the ovaries? If they do a surgical procedure to remove the ovaries, then that is actually coded in that endocrine procedure field in the treatment area. But we're probably common drugs. Tamoxifen is very common, anti-estrogen. Some of the other ones that you'll see is the Femera, the Arimidex. But don't forget SHRI will help you decide if what you're seeing is an endocrine hormone drug and to code it that. Okay, so Herceptin is only for HER2 positive breast cancer patients. This is found in about 25% of the patients. Herceptin is considered one of the targeted therapies for HER2 positive patients. There are some other drugs listed here. It is often given with chemo, but it could be used alone, or it might be given if they have a series of chemotherapy, and then once that stops, then they start the Herceptin, and that might be given for a year following the chemotherapy. These are not considered breast therapy. These are ancillary meds, except for Xgeva. There is a note in SHRI of when to code that as a BRM or when not to code it because it is considered ancillary. So a lot of these drugs will relieve bone pain or prevent bone loss. So treating bone mets is different, obviously, because it typically is not first course. But SHRI gives you direction on how to code those. So here are just a few other targeted therapies. I don't know if you'll run across these or not, but you can look these up in SHRI. And then some other drugs, immunotherapy, Keytruda is probably something you've heard of in the news. There are parameters as far as maybe these are given more for cancer patients who have been through the first course therapy, or they have persistent disease, they're not responding, they have refractory breast tumors. Same thing with clinical trials. Those will be very evident in the record because they will talk about the parameters of if they qualify and what arm of the clinical trial they are on, and they will be followed differently based on that protocol. All right, if you have any questions, feel free to email me, and thanks for listening.